So we are members of Phi Theta Epsilon at Grand Valley State University. And our project right now that we're working on is collecting information from like emerging practices or specialties. And we're going to compile all of these interviews and disseminate the information just so we have a better idea of how we can also serve communities as OTs once we graduate. So, Catherine, would you like to briefly introduce yourself and tell us about your current role as an OT and how it connects to addressing sexuality and intimacy?
Sure. So I'm Dr. Catherine Ellis. I go by Catherine. I'm an occupational therapist and an AASECT certified sexuality counselor. I'm also the founder and CEO of the Institute for Sex, Intimacy, and Occupational Therapy, which is a continuing education company for occupational therapists to help them understand, be better prepared to address sex and intimacy with their clients. So in my clinical practice, what I do is I get referrals specifically for sex and intimacy. So people will come to me for any number of reasons, but I think primarily a lot of it is work managing chronic pain, managing depression, anxiety. After a polytraumatic injury, they may need help with positioning. I have a connection with I get a lot of referrals from the pelvic floor physical therapist. And so I work with a lot of people that have pain with penetration, low desire, difficulty with orgasm. So that's kind of what my clinical practice looks like right now. And the way that I approach it is just from that occupational therapy lens. I know I shared that I was a sexuality counselor as well. I think more of the work that I do actually falls within occupational therapy. So helping people, I like to ask people like, what are the physical, cognitive, and emotional components of you engaging in this activity? And then where are you having difficulties? So then I attach intervention to where people are having difficulty with it.
Awesome. Well, welcome. Jacqueline, same question for you. If you'd like to briefly introduce yourself and talk about your current role as an OT and how that connects to sexuality and intimacy.
Yeah, definitely. So you guys kind of caught me at a weird time. I actually just recently changed roles. So my name's Jacqueline Rav. I'm an occupational therapist. I previously worked out of the Milwaukee VA, where I did the majority of my learning and growth in terms of sexuality and OT. During my time there, a lot of my work was done in a population with spinal cord injury. My colleagues and I created an interdisciplinary sexual health rehab program because we noticed that need was not being formally and cohesively addressed. So we created a team with a nurse practitioner, OT, nurse, physician, PT, PRN, as well as a pharmacist and psychologist. Did I say those people too? And we created kind of a formal rehab program for veterans with SCI to address sexual health. And then from there, I worked in whole health, which is more of a wellness and holistic type setting, where I did health coaching, which is more like one-on-one, mostly verbal treatment. I didn't really do any hands-on with that setting, but we worked more on the mental health side of things. So anxiety and stress management with sexual activity, relationships, that kind of thing. And then I just recently transitioned, like in the last 3 weeks, to a new job in Michigan at the Battle Creek VA, where I'm working in home-based primary care. So I essentially go into the veterans' homes, and it's with a very chronically disabled population in terms of multiple illnesses and really complex things going on. So I have not yet honestly figured out how I'm going to incorporate it into my current role. I'm still kind of feeling it out and figuring out the best way to approach it.
So to kick things off, Catherine, the first question is going to be for you. And you brought this up a little bit as you were introducing yourself. The question is, what is the process of becoming an AASECT certified sexuality counselor, and what benefits has it brought to your practice?
Sure. So the process is to be an AASECT certified counselor is, I think that you have to be in the field for maybe 3 years. You have to do a certain number of hours of sexuality intervention. And then you also have to do like 120 hours of training and 30 hours of supervision. And that's one-on-one supervision. So I pursued it because I felt like there was not a lot of options within the OT profession to get more training. I was also able to receive funding for the certification through my position that I had at the time. And so the benefits to my intervention and my practice, I think, are just the idea of the training. So just learning and absorbing all of the information. Sometimes we do self-study, sometimes we read research articles, and sometimes we're attending a course. So it's the aspect of the training that I have found most helpful, and just being able to think about how it would apply. Now, I also know that this sort of specialty is lacking within occupational therapy, and then this sort of specialty education is lacking within occupational therapy. So developing my education company was a way to fill that gap. And I am also working on a certification that would feel more applicable to occupational therapy for topics of sexuality and intimacy. I felt like the AASECT certification sometimes was lacking that disability component. It was lacking the way that it would apply. I think that sometimes I felt that occupational therapists view it, any occupation, as much more holistically. And so I think there was just kind of like differences in that I saw we could craft something better within occupational therapy.
My question is for Jacqueline. So I watched your presentation that you did for our guest lecture class in adult, and it was superb. I loved it, first of all. So my question, in your presentation, you discussed like the assessment process and having your the client's significant other involved when it's appropriate. So do you tend to wait on doing the assessment until the significant other can be present? Or do you try and get input separately from the client and then kind of compare their perspectives with that of their significant other?
So my best answer to this, and it's the most generic, is I always leave it up to the client. Now, say the client goes, well, what would you recommend? What would you prefer that I do? And they open that door for me. I kind of just gauge if there's a spouse, a partner, a significant other present, I kind of gauge the dynamic of the relationship to make my decision. So especially in, working in, say, the SCI rehab setting where it's an acute, spinal cord injury, you can kind of tell right away if there's strong family support, if their relationship has tension, if there's, underlying things going on. And I use that to make my recommendation. So say someone has a really engaged, supportive partner, they seem to have a loving relationship, they're pretty open about things, just like in our assessment in general, when they're working with other practitioners, then I might say, why don't we do it together? If I sense, though, that there could be like maybe one personality that's stronger than the other, or some underlying things that might be going on in the relationship, then I prefer to do it separately, because I want to really hear from, I'm there to serve the veteran. The family is obviously part of my treatment plan, but at the end of the day, if I sense that, there's a spouse or a partner that's going to overpower the evaluation, where I might not really get to hear from the veteran and really what they're thinking and feeling, then I prefer to do it separately first and then come together.
Jacqueline, I do the same thing. That's exactly how I handle it.
Yeah, I'm like, because you can always tell too, most times. Like if you're doing an OT eval and you're asking your client, how do you get dressed? And then the wife is like, or the partner is like, oh, they do it this way. You're like, okay, I didn't ask you.
Yeah.
But sometimes that's really good too.
All right, I'm going to switch gears a little bit and go back to Catherine. Catherine, this question is kind of multiple questions in one for you. What was the drive behind redeveloping the definition of sexual activity in the OTPF and adding the intimate social partner aspect? How did the process begin? Was it a team of OTs? Where does it stand now? And how can we as future OTs help to advocate for it?
Okay, I love this question. I'm actually going to bring that up so I can just. Okay, so this was a really exciting project because, spoiler alert, it was successful. So that's the status now. So the drive behind redoing the definitions was just because the definitions were, I felt that they were ambiguous, not helpful, not current. I thought that they were kind of perpetuated some harmful stereotypes as well, and just misinformation. So the world of sexuality is just filled with like misunderstanding, misinformation, toxic messaging. So it's really getting clear definitions, one, for the profession, because a lot of times there's just so much ambiguity and confusion within the profession of how we're supposed to address this. I thought, okay, well, our definitions aren't really that clear. So duty to one's spouse. And then another one was receiving pleasure or something like that, right? So for reproductive reasons, yes, got that. But there's, of course, other reasons. And then the duty to one's spouse, I felt like that was, yes, that does occur, but for that to make it into the definition, I thought was a little bit unclear. I also thought that was kind of perpetuating, that it being in there is kind of implying that that's somehow healthy. And it's kind of up to yes, there are some scenarios where that is culturally acceptable or that is, the norm. And it can be positive or that can be a very negative thing. So making that specific thing in the definition was really kind of strange to me. And then also, the idea, and again, I can't quote it, but it was implying that sex. Yes. So the definitions were not clear, and again, don't quote me on it, but it was somehow implying that the experience is always positive and desirable. But we all know that sexual activity is not always positive and is not always desirable. So again, it's kind of like reinforcing these, concepts that are confusing in general to deal with. And then the intimate social participation one was just also very unclear. So I felt like we needed better definitions. I had drafted some definitions and worked with a team about 3 or 5 occupational therapists, and wanted to make sure that they were had diverse perspectives, multiple, different identities were able to participate, OTs that had different identities. And then, so we drafted these definitions, and then I utilized the social media platform and my email list to kind of spread the news on this as a advocacy campaign. So I made, with advocacy campaigns, it has to be easy. I made it very clear what the steps were, how to, fill out the template, where to send the letter to. And so it was a very kind of easy step-by-step process for people to advocate and feel heard. That was mostly done all of last year. And then this year, there was a small little push where they did adapt the definitions, but in the revisions, they had changed the word sexual activity to sexual intimacy. And that was also a last minute push to get that changed back to sexual activity, because I think that sexual intimacy, again, it adds that layer of bias. Not everyone that engages in sexual activity finds it intimate. And so it's sort of that idea of let's have the most bare bones definition and then be able to add the kind of cultural relevancy or personal factors on top of that. So that's where we stand now. Now the 4th edition is completed, and it did go back to sexual activity with the new definition. So that's really exciting. Not all of the definition got adopted. Only some of the definition got adopted, but I do think that it is better from where it was. We'll just advocate again next time for even better definitions. And so for the future, I think like that's a huge area of advocacy, but then also our ACODE standards. So our ACODE standards do not involve sexual activity or intimate social participation. And then for that reason, it does not get addressed in schools. All of the things that are taught in school have to get attached to those standards. So my, big push next time around is for, a similar advocacy campaign to have things like sexual activity in the standards and implicit and explicit bias training in the standards, understanding the role of racism and sexism and genderism in general will be very important. And then, of course, in how that applies to sexual activity and, intimate relationships.
Our next question is for Jacqueline. So when you were working at the VA, how far do you go with addressing like sexual activity with your clients? And do you ever get to the point that it might feel like you're crossing more into a counseling session than skilled OT intervention? Just how do you find that line?
So elaborate for me a little bit on what do you mean by how far do you go?
Just, I guess, how do you delineate the boundary between making sure that you're still providing skilled OT intervention versus kind of crossing into where it would feel more of like a counseling session?
Okay, gotcha. That's a great question. There's definitely times where, like, I don't know, sometimes you get done with a session, I'm sure Catherine can relate, where you're just like, what just happened? Like, did I do anything to help this person? So I guess the way that I can best answer this is just by saying that I view our roles as OTs as counselors and educators in some way. I'm not AASECT certified as a sexuality counselor or a sexuality educator, so I can't clearly speak to kind of that, like by definition, what the delineation might look like between a sexuality counselor and an OT who addresses sexuality. But I think the beauty of OT is that our scope is so broad that it allows us to practice in so many different ways, in so many different settings. So like, obviously, I think it's important to remain skillful and intentional about the interventions that we're choosing to use with our clients. But at the same time, I think that, say you spend 30 minutes with a client and they are just talking and venting and working through things for themselves in their own head, I think that's therapeutic and skillful in and of itself as well, because that allows us to get to the next part of our treatment plan for OT. So that's a tricky question, and I'm wondering if Catherine has any other insight on that as well, just being that she also is AASECT certified. But I guess in a nutshell, I think our role as OTs is counselor and educator, and just being intentional about rooting back to your skilled OT interventions is important.
Yeah, I don't think that this is like, I think we need to not stop being worried about stepping on other people's toes, or thinking that we're doing something outside of our scope. When sexuality and intimacy are within our scope and we're doing occupational therapy intervention. We're educating, like Jacqueline, you have experience doing behavioral health. Yeah, I mean, behavioral health is a lot of talking and it's a lot of helping people through things and making suggestions on like a clear plan forward. Some call that counseling, some call that occupational therapy. So I encourage people to not get too hung up on thinking, what am I not allowed to do and not allowed to say? Trying to help people be independent with their occupation. And I never advocate that you need to be an AASECT certified sexuality counselor in order to do that.
And another thought too that I have on that is, like, a big part of what I focus on in a lot of my sessions is communication. So if by allowing, 30 minutes, creating space in my sessions for my clients to just talk and vent and work through things, I think that's kind of reinforcing a skill that we're going to be working on in our sessions anyways, of communicating their boundaries and what they expect and, you know, that kind of thing with whoever they're engaging in their intimate occupations with.
Yeah, I think we can get like so hung up on the idea that there's this partner. You know, for someone that has a spinal cord injury, you're working like helping them script how to advocate for themselves when they're out into the community and they can't open a door. Or they can open a door and they don't want a random person to do it for them. So we're always working on these things.
The next question I have is for Catherine. Do you collaborate with other OTs and health professionals to expand your knowledge and experience with addressing sexual activity in practice? And how do you go about networking and building those relationships?
So we'll talk to any OT that wants to talk about sex and intimacy. That's definitely something that I've had to do at work. And then I would say from an interdisciplinary standpoint, it'll be interesting. I'm curious what Jacqueline has to say too. But at my place, this wasn't really present. I had to not only explain my services, but I also had to educate and give suggestions on how another provider could bring up sex and intimacy in order to see if that person would then want to come and see me. So I have always had to do the, hey, this is what I do, but also let me do some education on how you can do this as well. So I've always had like an educational component there.
In your presentation, you briefly touched on cultural aspects and considerations as they related to the LGBTQ community. Do you find it helpful to network within this community to stay up to date and culturally sensitive with terminology and developments?
Yes, would be the best answer. And my most honest answer is I have not had much experience in working with anyone that's LGBTQ+. So I've done I regularly try to do continuing education on what I can find online or through the VA. There's lots of online courses through the VA. And then with a handful of people that I have worked with that identify as LGBTQ+, I think my best recommendation is just to rely on your basic skills of being an open listener, not afraid to ask questions, and embracing that non-judgmental attitude that you do with every other client, with every other occupation that you're working on. I can think of one in particular who I worked with, who she was just like so awesome. And I think being real with her that I was like, I'm not fully comfortable. I don't know what to say. Like, I don't know how to ask these questions. And just being honest with whoever you're working with that you don't know it all either and that you're willing to learn. I think that's a big thing. So she was just great. She was like, just ask away. Like, I'll tell you. So being mindful of that, and obviously any networking that you can do and opportunities that you can find will bolster your skills. But I think when it comes down to it, being confident and real with your clients, that you're there to learn from them as well. You don't have all the answers, and they are the expert on themselves. So like one thing that kind of stuck with me was the way that she identified her and her partner. So I guess, I don't know, in trainings that I've done before, I was a little confused about whether or not to call, like if a gay man has a husband, do I call it their partner? Do I call him their spouse? Do I call him, like, what do I call them? One of my best friends is gay, and I'll ask him this, and he's like, Jones is my maiden name. I don't know, just say whatever. So she referred to her as her wife, and I was like, duh, like, why am I making this a big deal? It's her wife, they're married. Like, so just being real with your clients and using a language that they choose to use and being open to learning, I think is a big recommendation that I can make for that question.
It says, how do you get your team members on board? And we're kind of asking this as like entry-level OTs that are passionate about this area in occupational therapy, and knowing that it's lacking out there. How do we step in and start to get that support from like other OTs that we might be working for or with or other team members in general?
So I think training is really important. So you have to do self-study, you have to take courses, you have to do training. I think that from my perspective, something that I've done is just show people what I do. So allowing OTs to shadow me, or they have somebody and they're like, hey, I think this person would be really great for you. And then I'll say, okay, like I'll come to your session. I'll show you what I would ask and how I do it. So I think teaching and showing is really, really helpful. And as new as entry level, like coming in, you might go to a place where they're not addressing it. And so then you have to do program development. And I think the best advice is like just get started. Like don't wait for permission. You're allowed to do it. Call me, I'll give you permission. Like we don't need permission. So getting started and getting going, and then you learn as you go. Unfortunately, like, is that the best way to go about it? No, but that's what we're doing right now because we're not being prepared as a profession. So it's like learning as you go, but then also doing the due diligence of your self-study and training.
I agree completely, Catherine. Like, I think too, as entry-level practitioners, like you guys are in such a cool spot because, I mean, that's how disciplines work, right? Like you have constant education, younger practitioners are learning new and different things, and you're certainly going to face barriers where it's like Catherine said, maybe it's not being addressed. Maybe there's an OT that's worked for 30 years and is really steadfast that that's not something that they do there. But knowing that you have resources like Catherine and I, knowing that other OTs are doing this, and knowing that our definitions are developing and changing, and it's in the OTPF, like I think you have a strong platform to make your argument and just get in there and start doing it. It can be really challenging when you don't have someone on site to kind of guide you and mentor you, but that's how I started. And I don't know, Catherine, but I didn't have anyone there either. We just kind of did it. So I hope that gives you confidence knowing that we just learned on our own. But I think as entry levels, just going in and being like confident in yourselves and knowing that you might not know it all, but you know something and you can bring that to the table. I hijacked that question because I'm passionate about that too. So I wanted to give you my 2 cents.
Factors do you think have contributed to the difference in comfort level in talking about sex between younger and older veterans that you've worked with?
Yeah, so I guess like the most observable differences that I've seen between a younger veteran population and an older is just kind of the younger population tends to be initially like just more open to discussing it, more relaxed. And I would say more open to trying different things. Whereas the older veteran population may be very like steadfast in their ways with sex and sexual activity and intimacy. That being said, and actually too, with the older population, I find that sometimes they need like a little bit more priming. Like I'll say it in my first session, plant the seed, and then a few more sessions, I'll kind of mention it, and then they kind of have to warm up to the idea of like, okay, let's do this. That being said, there's exceptions to every rule, so I wouldn't say that that's a broad sweeping, like across the board thing. I've certainly had older veterans who are like, yeah, let's talk about it. Let's talk about sex. And like right away and dive in. And I've had younger veterans that are the opposite, where they're a little bit more like hesitant or bashful talking about it. So I think a lot of it really comes down to like cultural differences and values and beliefs are a big part of it too. So yeah, I guess that's kind of what I noticed generationally. And just thinking about too, like, a veteran who's 80 years old maybe back in the, 80 years ago. And I need to do better research on this too. I was kind of Googling some things before I got this call. But it was really taboo, and it still is taboo. But 80 years ago, it was more taboo. And thinking of Catholicism being kind of the basis for a lot of the United States, kind of what's acceptable in terms of religion. So keeping that in mind too, that some older veterans may be kind of very steadfast and passionate about that. So overcoming that boundary as well. But yeah, I think the biggest thing off the top of my head is just younger vets seem to like generally latch on, and the older vets take a little bit of convincing.
Catherine, this question's for you. I know you have developed some continuing ed courses yourself addressing sexual activity, and Melissa may have taken one of those already. But what other courses or ways do you recommend that we expand our knowledge base on this topic?
I mean, Google CEUs for sexuality. I think that would be very helpful. So you're asking like what other courses? Oh, okay. Other than like Googling just that, I mean, I think that any course that would teach you how to explain activating the parasympathetic nervous system, that's going to be helpful. Any course that's going to teach you about trauma-informed care, that's going to be helpful. Any course learning about maybe breathing techniques, that's going to be helpful. Any course that talks about how to have enjoyable sex, that's going to be helpful. So that might not be like a professional course. That might be professionally done, but targeting like the end user, you as the sexual being.
Thank you. Jacqueline, my next question is for you, and you kind of touched a little bit on it already. So you mentioned that you built this interdisciplinary team at the VA because you found that sexual health wasn't being addressed. So I guess how did you get there? How did you find yourself specializing in this field at the VA and making that program? How'd you go about doing it?
So, like I said at the beginning, Catherine was like my catalyst. I went to AOTA one year, and so I was probably like a year in. Had just graduated. I started at the VA, and I had a really awesome coworker who I love dearly, and I miss her. But she had just started at the VA too, but she had a couple more years of experience than me. So she kind of took me under her wing, and just at the same time, we both were kind of like noticing with our clients that, hey, like, have they brought this up to you before? And neither of us really knowing like what to do or how to go about it. So one year I went to AOTA. I think it was probably like, I don't know, 2017 maybe. Did you present 2017, Catherine?
So did you go in 2014 when it was in Nashville?
No. Well,
okay.
I was a student at that time, so I'm not sure.
Oh, okay. 2017 was in Salt Lake.
Yes.
I don't know.
Yeah. One of the years.
Yeah, okay.
I went to AOTA and saw Catherine, and then just like made it my mission that anytime I was at AOTA, I was only going to like sex talks. So I saw Catherine, came back, and I think I saw like maybe one or two. I'm trying to think of their names off the top of my head, but I can't remember. Sharon Pavlovich, I think, was one of them.
Yes, yeah.
At that same time. So I came back to Milwaukee and was like, Katie, like, I've learned so much good stuff. We need to start doing this. Like, let's figure out how we can get this done. So that was happening in our OT little world in Milwaukee. And then kind of simultaneously, we didn't know this was going on, but one of the physicians in Milwaukee and SCI was also having discussions with her physician team about how sexual health wasn't being addressed. So the stars kind of aligned, and she approached us with, hey, is this something that you guys would want to be like get started doing? And we were like, heck yes. So we worked with the physicians initially to just start brainstorming. So this is when, Catherine's talking about program development. This is what we did. That's what we had to do it because there was no other skeleton or groundwork or anything for us to kind of build on. There's certainly some research articles about suggested best practices, but we couldn't really find anything about like a team, like an interdisciplinary team. So that's kind of how it was born. And then we, recruited, just kind of felt out other staff that were there and who would be interested in joining us. And fortunately, many of them were easily convinced and on board. So then we recruited the psychologist who traditionally in SCI in that setting had been the one that was most prominently talking about sexual health. So they were like, yeah, of course. And then we got the nurse practitioner, pharmacist, and nurse to join. And PT was not as gung-ho about it. So they kind of just joined in PRN, like if we had a unique positioning like need or something like that. So we got our team formulated, and then it was a lot of standard operating procedure development, writing and rewriting policies. We reached out to other VAs to see if anyone had any kind of policy in place to walk through like what a conjugal visit is or what can or can't be addressed in a hospital setting. And our drive as OTs was really, we had a independent living apartment up on the SCI floor. So veterans can go in there overnight. It's like fully functional with a kitchen, bathroom, bedroom, living room. And we knew that our long-term care facility at the VA had policy written in for just conjugal visits, which is that's a pretty narrow focus when we're talking about sexual health and intimacy. But we kind of use that as our selling point to our division manager of like, hey, this unit already is kind of doing some form of this, so why can't we? And they bought it, so then we were able to write our own kind of policy, and we kept it very, to Catherine's point too earlier about the definitions in the OTPF, we kept it kind of vague and broad, so that we could then like add on to it, and kind of most things would fit into the definition that we created for use of our apartment. So I don't know, I guess that was kind of a long answer, but that's really how it got started, was stars aligning, and passion, I think, was a big thing too. And then we just went from there.
I feel like it was that way.
I have a question for you, Jacqueline.
Yeah.
Would you, or have you like shared the program that you've developed with other hospitals or even other VAs to try and promote the development of it in other areas?
Yeah, so we actually just wrote and published an article. Thank you for asking. So we just got published in a journal called Sexuality and Disability. And then we have presented to the OT field within the VA, our team has. But we need to do more, honestly. I think sometimes as people, we don't like tooting our own horns. And I think you're right. In this case, I think we should do more of that. So I'm going to add that to my list. I'll reach out to my old team and encourage them to kind of share it or send it out somehow.
On your website, you discuss doing in-depth evaluations, and we understand that this looks different for each client, but can you give us a little glimpse of what an evaluation would look like just from your perspective?
Sure. So I bring people in, I explain what occupational therapy is. I explain that I talk about sex all day long, and so I'm very comfortable with the topic, but that I understand that not everybody is. and I share, I say, I'm going to ask you some really personal and intimate things. You do not feel like you have to answer them. I want to create a safe environment for you, but I don't know, it's impossible to create a safe environment for everybody. So if there's something that I could do better, please let me know. So that's the sort of like way of approaching a more compassionate environment and trauma-informed care environment, because I do ask them a lot of detailed questions. So I ask the sort of typical questions like, hey, are you in pain? Do you have pain when you have sex? Do you feel anxious right now? Do you feel anxious when you have sex? I want to know what their relationship structure is like. If they're with, if they have an intimate partner, if they have sexual partners, if they're monogamous, non-monogamous, open relationship. I ask the kind of lifestyle questions. So, how is sleep? How is stress? Where do you have sex? When do you have sex? What does it look like when you're having sex? I often say, tell me about the last time that you had sex. What did it look like? And then I want to hear from them, why are they here? So I want to know what's the problem and what would better look like. And then I ask them more questions about the intimate relationship, how that is going. How do you feel that intimacy, the emotional intimacy, show emotional intimacy, and are you satisfied with that? I always ask about reproduction, whether people are trying to get pregnant, trying to not get pregnant, and if they're doing the right steps to not get pregnant. I have had clients get pregnant unintentionally, so I have to ask that question every time. Then I ask them about their desire, their arousal, and their communication. I ask how they masturbate, and I ask how they orgasm. So that is first off, I just did that. I can't believe I think I did that in 90 seconds. That is not meant to be a quickie, okay? That is an hour-long evaluation. But that is what I'm asking.
In your presentations, you said the brain is the most sensitive sex organ, and mental health can greatly impact sexual functioning. How do you address mental health concerns in treatment in order to ensure that they can still achieve their goals surrounding sexual activity?
Yes. So know your limitations is my first instinct to answer this question. So we're OTs and we're awesome, but there's professionals that help address mental health. So there's obviously certain things that are within our practice as OTs to address mental health, cognition. But if it gets to, if you try some of those things, or if you note something that is so underlying or really severe that it's out of your scope, it's okay to admit that and bring in someone else that can help you. So co-treating with psychology can be really helpful. Not only does that give you that team aspect of your treatment, but then you learn some stuff too when you're in there with a psychologist and they ask different questions and help the vet or the client. I did this in the lecture too. I always say veteran just because that's how I work. But they help the veteran work through things that you simply can or don't have the skill set to do. So co-treating with psychology is huge. And in the veteran population, some things that might require that would be past sexual trauma, military sexual trauma, PTSD, really severe underlying depression, things like that, where it's as the OT, I cannot treat those. And if it's not treated, it will likely get in the way of our progress towards our sexual health goals. But then more OT specific things that I do are that anxiety and stress management piece. So I teach my veterans mindful awareness, meditation, journaling, breathing techniques. So I oftentimes will just ask them, what do you find to be stress relieving? Because it's different for everyone. Someone might say listening to music or dancing in my car or, whatever. And I'll say, do that. Like before you self-pleasure or engage in sex or think about going on a date or whatever it is, do the thing that reduces your stress. Journaling, gratitude practice, any kinds of those skills I like to reinforce and teach in my sessions and tie them to whatever sexual health or intimate goal that we're working on. Another example that I think I may have told you guys about is I had one veteran who was like super anxious about everything. And it's just a cycle of anxiety about performance and then underlying anxiety, and then it creates more anxiety. So what I had him do was he played, it's kind of funny, he played Mariah Carey every morning before he used his tumescence pump. And he was supposed to do a breathing exercise, but he never did because he just listened to Mariah Carey until he relaxed enough. So tying in those creative stress management interventions and anxiety management interventions that you can and connecting them maybe just in a different way than what you otherwise would, I think, and tying them to your sexual health intervention is where as OTs we can be really helpful.
As Jamie mentioned, I've taken some of your CEUs on your website, but also on your website it mentions how you offer interested students consultation and coaching to enhance our skills addressing sexual activity and intimacy with our future clients, coworkers, and students. Can you just share with all of us a little bit more about what that would look like?
Yeah, yes. And it's for anyone that, student, occupational therapy professional, anyone that is hoping to, ask all these questions. Anyone that is interested in talking one-on-one about a client that they have, or talking one-on-one about how their progress is going with program development. So, and I have, a lot of times I receive a lot of questions, a lot of emails, a lot of requests to just talk. And so that's where those services are. I also have a group coaching program development course that's 6 hours, it's 6 CEUs over the course. It meets every other week for 12 weeks. And I run that in the spring, summer, and the fall. So right now I'm in the summer cohort, and the fall cohort will be in the fall. But that is more where we have a group of people that are coming together, and we have a structure each session. But it's another place for people to kind of toss around ideas, ask questions, organize, plan, and learn from each other. So I just find it's one way to continue helping people engage on the topic when they feel like they don't have anyone to talk to about it.
Perfect, thank you.
Jacqueline, my next question is for you, and Catherine, you could probably speak to this as well. It's a little more broad. So how do you address psychosocial factors like shame or embarrassment during treatment, since this is just such a deeply personal area of occupation? Are there any strategies that you use to help your clients just feel empowered?
Yeah, definitely. So I made a list for this one because I wanted to give you guys some good ideas. So I'm just going to kind of go down my list and tell you what I came up with, okay? So the first thing I wrote was self-reflection, so encouraging them to really take time to reflect for themselves, and then offering them reflective listening at the time of the session that you're with them. So I think I've really come to... over the last 4 years, I've really come to understand the value of just listening. I've witnessed a lot of other medical professionals as well as myself when I was just starting out, and certainly there's times that I lapse now too, of wanting to just give everything that I know and talk, and I'm the one that knows what I should be talking about kind of thing. But there's so much power in just listening and repeating back what your client is saying to you. Either, a few words of what they're saying, or summarizing, paraphrasing what they're saying. Letting them be heard, I think, is one of the biggest and most powerful things that we can do. And I think listening, reflective listening, paraphrase, summarization, are all ways that we can show that we're listening. A sense of humor, I think, is really important. So, you know, the way that you come to your session and the way that you're feeling about the topic, the client will pick up on that. So if you're feeling bashful or if you're, you know, shy about it, it kind of reinforces that idea that they should be shy and feel shame as well in talking about it. So I think having confidence and, you know, embracing a sense of humor in the topic is really important. Again, like I said earlier, being non-judging, and ways that you can do that are checking your own biases, reminding yourself why you're an OT, you know, body language, making sure that you're aware of your facial expressions, using the client's language is a really great way to show that you're non-judgmental about a topic. Like I said earlier, creating time and space. So pausing, giving the client time to think, respond, that creates a safe, supportive environment for them. I think self-disclosure can be really powerful when appropriate and when you're comfortable with it. Like letting them know that you've been there in some way too, or that you're working through things too. Letting them guide the discussion and plan. So this can be kind of a delicate act because I think a lot of the times clients look to you as a professional to like guide them down the path. Yet I'm looking to my client to guide me down the path that I'm guiding them down. So allowing them to do that, of asking, you know, open-ended questions. What do you already know about this? What would you like to know about this? What are you willing to try? What have you tried? So allowing them to kind of take your hand and be your GPS while you're helping them go down the road, I think can be valuable. And then lastly, I have on here is work on yourself too. So practicing, scripting, writing your elevator speech, doing your own research and self-study, acknowledging your own shortcomings to the client, and, you know, being real with them. I think just that genuity, being genuine, I think is a great way to empower them and let them feel comfortable in talking about it with you.
What type of support or resources do you provide to the significant others that may feel neglected or distressed by the change in their relationship?
Okay, so that is called, it depends on why they feel neglected. What's going on there? Why does somebody feel neglected? Okay, so you're trying to get them to effectively communicate why they feel neglected. Then you're trying to see if the other partner is on board or cares to fix that issue. And then you're trying to give that partner the skills and strategies to fix that. If it's neglected, I'm thinking of the term a desire discrepancy. So every relationship has a desire discrepancy. It is impossible to have two people that want sex at the same exact frequency, at the same exact time, at the same exact day. So helping people understand that a desire discrepancy is actually very normal. You need to see if both partners are on board with closing that gap a little bit. And then trying to see, if it's the person that, what's hard is that when there is a feeling neglected or a desire discrepancy, is that it's the person that wants it less that always feels like they have to do more work. Like, oh, if you could just want it more, then we wouldn't be in this issue, versus if you could just want it less, then we wouldn't be in this issue. So I try not to what we're really getting at, and again, it's if both people care. If one partner comes in and says, I do not want sex, I don't care for it, I don't want it, and quite frankly, I'm fine with that. I don't want to change that. And that's their goals, and there's nothing we're going to do. If they come in and say, I don't desire sex and I want to desire sex more, then we got something to work with. If you have someone come in and say, my partner doesn't want sex as much as I do, and the partner is not there, not a whole lot you can work with, and you're just trying to build insight. Well, have you ever asked your partner why they don't want sex often, or why they say no to sex? More often than not, they'll say, well, sometimes they say no, and sometimes they say yes. They know the answer, and they still don't do anything. They don't do anything about it, which I think is very funny. So, a lot of this is communication. And a lot of this is people feeling like they have the skills to be a better partner. There's a lot of inadequacies within couples. And it's a lot of our job is helping people deal with that feeling of shame and inadequacy so that they can realize that they can actually be a good partner, or the partner they want to be, or their partner wants them to be.
In your presentations, you mentioned barriers to intervention, like myths and around sexual activity, taboo, personal values, lack of knowledge, and unclear boundaries. Are there any barriers that exist on a larger scale, like systematic or ethical factors when addressing sexual health or activity?
Yes. That's the answer to your question. So like thinking of it systematically, so all those things that you just listed, myths, taboo, personal values, lack of knowledge, etc. When you think of that in a systematic level, and all of that's compounded, it can make it really challenging to get that support and buy-in from like leadership, admin, your other colleagues and staff members. So I think that's where my brain goes when I think systematically. Granted, I really only have 2 settings to compare this to, and in both settings, I don't know if it was me or the people that I was working with, but I've been fairly successful in getting people to be on board. But I know that can be a problem from other, colleagues that I've talked to in different settings of successfully implementing something. And I think a lot of the times that systematic challenge and all those other smaller things like myths, taboo, etc., manifest in hospital policies. So policy can be really challenging too, because either it's not written in, so there's a lot of ambiguity, like just unclear guidelines or expectations on what you can do and what you can't do and who's doing what and this and that. Or just nothing exists, then you have to build it. So I think that just adds a layer of challenge. The other thing that came to my mind was like insurance policies. That's another barrier. I'm fortunate in that working in the VA, I don't have to interact as much with insurance companies, but in our end, it's prosthetics. They're like the equivalent of insurance. So it can be really challenging to acquire certain devices if we're working on modifications or anything like that, just based on, because like our prosthetics department kind of bases what's medically necessary on what insurance might say in the private sector. So it can be challenging to make an argument about what is medically necessary for sexual health, just because, again, not everyone is there and not everyone is on the same page of what we're working on because of all those other reasons. So that can be a challenge. And then ethically, I think what comes to my mind more that like resonated me with a few times when I've heard this in the past is more like educationally. I've heard of schools that are like, Catholic schools or where because they're based off of Catholic tenets or, whatever it might be, they're not including it in the curriculum, which I think is kind of the root of some of the problem because then we've got I mean, in traditional OT programs, I would say maybe you get like an hour of education on it, which is not enough in general. But then to have programs where they're not even like giving you an hour, I think that is a huge barrier. And I'm excited to hear, Catherine, I love hearing that I know you've been working on that too, and I'm excited to hear about what happens with the ACODE standards because.
Yeah. Yeah, I mean, it all has to do with ACODE standards because the issue is we think that the ACODE standards will give permission, which they will, but they will also give protection. And so I have heard of a student getting in trouble for bringing it up, and I have heard of a faculty member getting scathing remarks from the students for bringing it up and also being held back on promotion for bringing it up. And so, you know, we think about it, oh, it's going to just grant permission. Well, it's also going to grant protection. So, you know, I think that we just have to be very aware of the foundation of our profession. It's very, you know, Western, white, middle class women, you know, a feminine perspective. And we have to be that sort of, you know, those cultures and Puritan culture and religious cultures. They are important, and we are allowed to have all of those perspectives and cultures and identities. That makes us who we are as people, but that does not make us who we are as OTs. Mm-hmm. We cannot let that is an ethical issue. So, no, I can't practice my belief system, my values, and my attitudes as a person. I cannot practice that in my occupational therapy practice. That's unethical. So we have to be very aware of where these influences are coming from and just being aware of that. You know, I think that there's a lot of dialogue on that awareness. And I think that, you know, for years that, you know, it wasn't always getting called out. My thought with ACODE and some of these other institutions, right? So like, let's just take a religious university that has you know, again, this wouldn't be all religious universities, but let's just take take religion out of it. A university that has in their mission and in their values, a value that conflicts with a value of ACODE or a value of AOTA. You know, how is that getting navigated? And ultimately, until there's standards in the practice, then that's not getting navigated. That's not getting navigated at all. So that's why it's so important.
Agreed. Because then it goes back to even just in your own personal practice. Like the way I look at it, it's kind of just like it just gets magnified once you go from person to system. Like when you go in your own personal practice and there's not a policy in place, it's kind of the same thing as when you go to that bigger system and there's nothing saying that they can or can't or they're protected or they're not. Then people are more hesitant to embrace it or practice it or teach it or whatever it is.
Do either of you have anything else that you would like to add?
I don't. I think I covered a lot, and the questions are really great. So thank you for hosting this.
I agree. I just want to say, like, I'm so proud of you guys. Like,
yeah, me too.
Like, I would have loved to be in your spot when I was a graduate OT student. Like, here, meeting with people and learning about it. Like, you guys are on a good track. So please, like, reach out to us if you ever have any other questions or anything like that. Like, happy to be a resource for you and keep doing what you're doing.
And I just want to personally say thank you so much, and you will definitely be hearing from me in the future.
Good.
Awesome. I look forward to it.
Thank you so much for just your time and your wisdom and sharing it with the next wave of OTs.
Thank you guys so much.
Thank you.
You're welcome. Thank you guys as well.
Bye, Catherine.
Bye, Jack. And good to see you.